You're welcome, everybody. Thanks for joining us this quarter for our Meningioma Support Group meeting. This is a event that we hold via Zoom 4 times a year to provide educational topics for patients that have meningiomas. So the topic that I wanted to talk about today is a topic that we haven't presented in the last 10 years or so, but it's something that I think is very germane to uh, meningiomas because whether I'm not sure how many meningioma patients know it or not, but meningiomas are a type of tumor that is very commonly influenced by hormones, particularly the female hormones. So by way of background, meningiomas, they're the second most common primary tumor of the brain and spine. The only tumor that's more common than that are gliomas, which by and large are malignant. But meningiomas are the second most common primary brain tumor and the most common benign brain tumor. You can see that we only have 1 to 2% of these meningiomas end up being what we call a grade 3 or malignant meningioma. Meningiomas often don't grow for years at a time, and there are probably some of you in the audience that have been following your meningioma, haven't had surgery or radiation, and perhaps it hasn't been growing. And then they're most commonly seen between the ages of 40 and 70, more typically after the age of 50. And in part, what we'll learn today is why that possibly could be the case from a hormonal standpoint. We'll also learn why meningiomas are 3 to 4 times more common in women than men. Okay, in terms of risk factors for meningiomas, we're going to talk about some of these before we get into the slides on the hormones. We know that proven risk factors for meningiomas include prior radiation. So we use radiation to kill tumors, but sometimes radiation is used for other reasons. Back in the 1950s, for example, low dose radiation was given to the head to treat head lice, for example. If you've had radiation to your neck, for example, perhaps the bottom part of the brain was exposed to radiation and could predispose you to meningiomas. But radiation exposure is one risk factor. A second risk factor is the neurofibromatosis type 2. It's a genetic disorder that is not that common, but in addition to tumors along the balance nerve, which are called vestibular schwannomas, meningiomas are fairly common in that type of genetic disorder. And then the third risk factor is the one we're going to focus on today, which is talking about estrogen and progesterone hormones, and to discuss what role they can play in the potential growth of meningiomas. While we're at it, unproven risk factors, prior trauma. I get asked this a lot, like when a patient is diagnosed with a meningioma in their brain. Sometimes there's a story of, well, I hit my head, when I was a child on that side, and could that be the cause of the meningioma? It's not the case. Viruses don't cause meningiomas. Cell phone use is often asked by patients, like, could my meningioma be a result of my cell phone use? And I think there's a large body of literature now, including a large study that just came out a few days ago, that shows that cell phone use is not associated with any increase in development of any brain tumors. So we can put the cell phone use issue to rest. This is a cross section of the head. So at the very top, we have the skull. We have the blue lining is called the dura. It's a kind of fibrous, leathery layer. Then we have the arachnoid layer, and then the peel layer, which is attached to the brain. So there's the three layers between the bone and the brain: the dura, the arachnoid, and the pia. And these are called the meninges, collectively called the meninges, and hence the name meningiomas, because they arise from the layers between the bone and the brain. Now, the actual layer by which the meningioma arises from is thought to be the middle of the three layers. So not the blue or not this pia right on attached to the surface of the brain, but this arachnoid layer is thought to be the source of meningiomas. So when people have started to suspect maybe hormonal influences on meningiomas for a while now. This paper is over a decade old, but you can see in this paper, the first sentence of the second paragraph, the evidence implicates gender-specific hormones. They're meaning estrogen and progesterone in the pathogenesis and the development of meningiomas. And essentially, the way they came up with this information is they noted that patients that had meningiomas that may have been stable or very slowly growing, often those tumors showed a growth spurt during pregnancy. And we know during pregnancy, there's a significant increase in these hormone levels. So this led people to think that maybe there's something going on with the estrogen and progesterone that leads to them being sensitized by these hormones. If you take a meningioma piece of specimen and take it to the pathology lab and look at it under a microscope and stain it for the progesterone and estrogen receptors, you can see that about 70% of meningiomas express progesterone receptors. That means they have hormonal receptors on the surface of the meningioma cells that can be somehow regulated by a progesterone molecule that attaches to that receptor. And likewise, about a third of meningiomas have estrogen receptors. Again, that's a receptor on the cell surface of the meningioma cell that an estrogen molecule will attach to and can cause some changes in the cell development. So to summarize that paper, we learned that during pregnancy, there is a boost in hormone growth rates. That menopause appears to confer protection, meaning that during menopause we have a drop in those hormone levels. That seems to slow or prevent meningioma growth. And then removing the ovaries also in those patients that need it removed for medical reason has been associated with a slowing down or cessation in growth of meningiomas. And here's the numbers that came out of those papers. So you can see you're just looking at these percentages, you can see why people would start to think that maybe the hormones are somehow related to meningioma growth. So if we know that pregnancy, we know that increases the estrogen and progesterone hormones, and that appears to increase the speed of meningioma growth. What about if you supplement a patient with hormone replacement therapy? So rather than have your body increasing estrogen and progesterone on its own during pregnancy, what if we gave a patient estrogen and progesterone? And this is what happens during hormone replacement therapy. And essentially, that is when a woman goes into menopause, they see a drop in the estrogen and progesterone hormones, and that's associated with potentially some medical issues such as early bone loss, osteoporosis, and things like that. So in addition, there's the potential hot flashes and other symptoms that can be often troublesome from going through menopause. So hormone replacement therapy is the supplementation of the hormones that normally drop during menopause. And essentially, you're boosting those hormones with these pills. And what this particular study showed was that those patients that were on hormone replacement therapy had evidence of development of meningiomas and growth of meningiomas compared to those patients that were not on hormone replacement therapy. So this would make sense because it doesn't matter where the hormone comes from within your own body, such as pregnancy versus being supplemented. Your body just sees an elevation in the hormone levels, and that can increase the development of meningiomas. So from that last paper, we see that there's a positive association with hormone replacement therapy and the diagnosis of meningiomas. That and this could also be with oral contraceptives too, which essentially is another form of oral hormone supplementation. And you can see it doubles the chance of developing a meningioma. And if you take a meningioma cell and go to the lab and in a petri dish, put the meningioma cell in the dish and expose it to progesterone, that seems to stimulate the meningioma cells to multiply. So this situation comes up commonly when we see patients in clinic that have a known meningioma that we're just watching their meningioma. Let's say it hasn't shown any growth. But now the patient goes into menopause and they're having a lot of symptoms, and or their primary care doctors talking to them about all the positive benefits being on hormone replacement therapy. So now it raises the issue of do we let the patient go on hormone replacement therapy, knowing that they have a meningioma, or do we tell them that it's best not to be on hormone replacement therapy? And there's no right or wrong answer here. I've managed it both ways. It really depends upon a couple of factors, including size of the tumor, the location, how likely it would be to become symptomatic if it were to get larger, how long that we've been watching the tumor prior to the onset of menopause. So I've had some patients where we've judiciously allowed them to use hormone replacement therapy. It may require obtaining MRI scans a little bit more frequently so you can stay on top of any changes that might appear. In other patients, they've been just worried about the increased risk and chosen not to go on hormone replacement therapy. So I think you need to individualize it to the patient. There's some more extreme cases where a patient might have multiple meningiomas, like 3 or 4 meningiomas, and are on hormone replacement therapy. I mean, each of the tumors independently now has a chance of growing. So it's not that it's not that the hormone replacement therapy is really totally off the table, because the data shows that even though there may be a 1.5 to 2 times higher chance of meningiomas, the overall incidence of meningiomas is not that high. And so this was one study that occurred in Finland, and a lot of the European countries with nationalized medicine, they can collect large cohorts of data because all the patients in the entire country get funneled into one data center. And this particular study, they looked at women who used hormone replacement therapy for at least 6 months after the age of 50 during a 15-year window. And the patients were all about evenly split, about 130,000 only on estrogen and 130,000 on estrogen and progesterone combinations. And you can see the numbers below. 290 patients with estrogen users were diagnosed with meningiomas, and 196 of the estrogen progesterone users were diagnosed with meningiomas. And so they calculated this was a 1.4 times higher chance of meningiomas if you just used estrogen. But interestingly, if you just used estrogen and progesterone combination together, that was not associated with any higher risk. So this does show that there may be potentially safe ways to give hormone replacement therapy in meningioma patients. So this is another study that basically found results that were very reassuring if you're on hormone replacement therapy. They looked at about 2.2 million patients. They found 745 with meningiomas. So, this is again this is about 1 in 3,000 patients or so. So meningiomas are not as common as we think. But in this particular study, there was no increased risk of meningiomas on patients that were either taking birth control pills or hormone replacement therapy. So this, according to this study, hormone replacement therapy would be safe to take. The Looking at progesterone and meningiomas, there's a couple of association with using anti-progesterone therapy for meningiomas. So the thought is that if progesterone and estrogen might stimulate meningiomas, if you gave the opposite type of hormone, anti-progesterone, maybe that would inhibit meningioma growth. That turned out not to be correct. So using anti-progesterone therapy did not like inhibit meningioma production. So here's the results of this particular study. We know that there's 75% of meningiomas have progesterone receptors, whereas only 30% have estrogen receptors. So progesterone seemed to be the more predominant of the hormone receptor for meningiomas. And an agonist is a substance that looks like progesterone. So if you give meningiomas subject them to a hormone that's progesterone or that mimics progesterone, it possibly stimulated growth. If you expose meningiomas to a drug compound that was an anti-progesterone that looked like it maybe blocked the progesterone receptor without stimulating it, then there are a few cases of perhaps the tumor stopped growing, but these are just anecdotal case reports. This was an anti-progesterone drug, mifepristone, and it was studied in a paper that was published in 2008. What they did is they gave this drug to patients with meningiomas, and they gave it to them for 3 years and then assessed the response. So what happened in this situation in terms of symptoms? If you give an anti-progesterone to patients, you're essentially putting them into a menopause situation. And so the patients got a lot of symptoms of menopause, like fatigue and hot flashes. But they did note that there was some potential blunting of tumor growth in about 8 of the 28 patients that had meningioma. So maybe some benefit there. It wasn't clear whether putting up with the side effects for that duration of time was worth the benefit. This is a same drug, a different paper that was earlier. They really only gave it to one patient, but for a 2-year period of time, and they surprisingly had a 73% shrinkage in the size of the meningioma. But then this was just one particular case, not a series of cases. So I do want to also talk about pregnancy. So let me back up a slide. How do we manage patients that are pregnant but have known meningiomas? Because unlike hormone replacement therapy, where you can halt the medication and halt the hormone levels, and during pregnancy, you can't really halt the hormone increases. Secondly, it's often more challenging to obtain MRI scans on patients that are pregnant just because of the concern of repeated high magnetic field exposures to the fetus. So, and this is a discussion that's often had with patients with known meningiomas that want to become pregnant, like they're trying to establish a family, and they may ask for some advice upon how to really manage the situation. So what I like to do for women who want to become pregnant but that have meningiomas is to make sure we have a good baseline MRI scan before they become pregnant, because in theory you may not be able to obtain an MRI scan for the 9 months that they are pregnant. So if someone's actively trying to get pregnant, I usually tell them, let's get a good baseline MRI scan if we don't currently have one. And then if the patient does become pregnant, we'll plan on obtaining an MRI scan immediately after the child is delivered, assuming the patient doesn't have any symptoms. So that's kind of one strategy to manage patients that are actively trying to become pregnant. The bigger challenge is the patient that is just maybe not actively trying to get pregnant, but becomes pregnant um, despite, let's say their birth control methods, become pregnant and don't really haven't had a discussion with the neurosurgeon prior to that. That's a little bit bigger challenge because some of these patients may not have a recent MRI scan, so we don't know what size the tumor was prior to pregnancy. Um, and in those situations, again, you try to be judicious. If the last known scan showed the tumor was relatively small in a non-critical area of the brain, I usually let the patient carry the child to term, and then I try to get a scan fairly quickly after the delivery of the child. Obviously, if the patient develops symptoms during the pregnancy, then you need to basically obtain the MRI scan to see what is going on. And that means, just balancing the risk benefit of obtaining the MRI during pregnancy. Um, the birth control pills, as I mentioned, are similar to hormone replacement therapy, are also oral supplements. Um, People take them for a reason, obviously, to either not become pregnant or to regulate their cycles, or to reduce symptoms. So again, the choice of birth control pills, if you have a known meningioma, you just have to, balance all the parts of the equation. If the birth control pills are being taken just for, anti-pregnancy impact, then there's other methods of birth control that could be used. If you're taking birth control pills to regulate cycle or control excessive bleeding, there's not a lot of other good alternatives for that. And then so again, it's just the judicious timing of the MRI scans to make sure that you can monitor these meningiomas, most of which are slow growing, but to stay on top of them before things get out of control. So this is on the left an MRI scan of what a human brain that shows a meningioma on the lining of the inner lining of the skull. Remember, they come off the meninges, hence the name of meningioma here. And on the right side, we have two other pictures, and you notice that the pictures on the right side don't look like the pictures on the left side. This upper picture on the right side, you certainly see the brain here. You see a meningioma right here along the base of the skull, but you see a pretty large amount of muscle here, and you see some floppy ears here. So this is a dog. The dog has a meningioma. So meningiomas can occur in dogs, and this one at the bottom is a cat. So you see little cat ears sticking out here, and the brain. And this cat is unfortunate, has a bunch of meningiomas. There's one here, has one here, there's a little small one there. So meningiomas don't just occur in humans; it can occur in these guys as well. Some of the hormone studies that I did not show today, but that exist in the literature, occur in cats and dogs, looking at the meningiomas and how they respond to hormone treatment in those organisms. and you can see that people have even written it up. Canine and feline meningiomas, how to manage them and then treat them. So this is, I put this in here more just as an interesting kind of fact that a lot of what we learn in our human management occurs because veterinarians manage meningiomas in dogs and cats all the time. So I'm going to open this up now to questions that people may have. I try to save at least half of the events for a question and answer period. So the way we'd like to have these questions submitted is you can just submit them through the um, question and answer feature on the bottom of the Zoom bar, and I will have those questions and I'll go through them one at a time to answer them. And I'm going to just start answering them now because there's already 4 questions that have been um, uh, uh, submitted. So the first question talked about if I had a craniotomy to remove my meningioma, should I still be worried about hormones? The answer is if the meningioma has been completely resected, you have had several MRI scans looking at the tumor and documenting that the tumor is gone. I really think there's not much of a risk that hormones will play in terms of causing any recurrence. So I would say I would not consider you a high risk patient in that circumstances. The second question talks about association with breast cancer. It's mostly the correlation that meningiomas have a association with the same hormones that breast cancer has an association with. So I think it's not that meningiomas and breast cancers are necessarily associated, but they're both correlated with the hormone levels. So they have a common correlative factor. Next question is the chance of meningioma growth dose dependent on hormone replacement therapy? And does the method of replacement therapy, such as patch, tablets, vaginal creams, etc., matter? My understanding is there is a dose dependency of the hormones. The method of delivery, I don't think has ever been studied. I would not expect a difference in the method of delivery. It's more the serum hormone levels that the meningioma is exposed to that determines the likelihood. And again, I'm not saying the likelihood is dramatically higher. We saw in these papers that it is either 1.5 to 2 times more likely than in a patient that doesn't have hormone replacement therapy. So given that meningiomas occur, in 1 in 700 patients, that's a very small number, much less than 1%. And when you double that, you still get a number that's much less than 1%. So it's a relative increase in risk, but the absolute risk is still very, very low. Next question is there any evidence of or a study on post-radiation treated meningiomas and hormone replacement therapy? I'm not aware of, and you're correct in that the assumption is that most of the research presented is largely based on meningiomas that are monitored. If meningiomas are large, are symptomatic, those patients are pretty much undergoing surgery. If the meningiomas are smaller but progressing on their own, even before hormone replacement therapy, they're usually being treated with surgery or radiation. So really the cohort where we have the most data on the hormone replacement therapy are those patients with smaller meningiomas. They've been relatively stable in size, so there was no indication to either radiate or do surgery. And then the patient then has to go on hormone replacement therapy. So that's the reason why it looks like that a lot of the studies are on just meningiomas in the watch and wait mode. Could EMF, I presume that means electromagnetic field, cause meningiomas? I'm not aware of any relationship between that. There's definitely EMF fields be associated with some forms of dementia and whatnot, but I'm not aware that it's related to meningiomas. Second question is being overweight or obesity a risk factor for meningiomas. I'm not aware of any particular study, and I'm just thinking through my patient population. I have not seen any kind of correlation for that. Next question. I have a small meningioma. Is it safe to use vaginal estrogen? Again, this is that whole risk benefit discussion. It depends upon the meningioma is small, so that's good. If it did get slightly bigger or bigger in size, maybe that would still be considered small, even if it did grow. But more importantly than the size is actually the location, because a small meningioma in a challenging location can become symptomatic even with a small increase in size. For example, if you have a meningioma wrapped around your vision nerve, a small increase in the size of the meningioma may cause you to lose vision. So this question is, it's overly general without seeing the films. It's hard to kind of give specific advice. It would have to be personalized based upon, age of the patient, how long you think you needed to be on estrogen, where the tumor is located, and what risks you're willing to assume. The next question, if a man has estrogen receptive tumor, is it hormone related? It can be. So all humans have estrogen, progesterone, and testosterone in them. The difference is the relative weighting. So men have more testosterone than estrogen, for example, but women have more estrogen than testosterone, but they still have some testosterone. So a man with a tumor, meningioma tumor, still could have some influence if they were exposed to hormones in that situation. So the next question is, if anti-progesterone treatment helps, is it possible to get treatments to shrink a stable meningioma? So that's a great question. The challenge in the first half of the argument about the anti-progesterone treatment helping is that the data is mixed. I showed a couple of papers where it looked like it was helping, but one of them was just one case report in a single patient. There's other studies that show that giving the anti-progesterone treatment doesn't help at all. So it's hard to say that giving that treatment would be associated with shrinking a stable meningioma. The other thing to keep in mind is that if a meningioma is stable for a number of years, let's say 10 years without any growth, and is not causing any symptoms, shrinking it is not going to really provide any improvement in neurologic function because the patient is presumably normal to start with. If the patient has symptoms from a meningioma, it's not likely that the physicians will be recommending just watching the tumor. If you came into my office with symptoms, we would most likely come up with a treatment plan. So I'm not aware of people just trying, outside of these studies, people trying anti-progesterone, but in a lot of the studies, there's been no benefit, which is why it's not typically used on a more common basis. What about corticosteroids' influence on meningioma? These don't seem to really, at least in my understanding of the literature, cause any rapid changes in meningiomas. Another hormone that does influence meningioma growth is the growth hormone that is secreted by in part by the pituitary gland axis. And those are associated with the increase in meningiomas, but not the steroids. The next question, as I had a craniotomy, which is a surgery to remove my meningioma about a month ago. Pathology is a grade 2 meningioma. So we know these occur on a grade 1, 2, and 3. So 2 is in the middle, about 10% of tumors are a 2. I was told that there's a higher chance of recurrence. That's correct. 2s have a greater chance of recurrence than 1s, and 3 have a much greater chance of recurrence than 2s. So the question is there anything can be done to reduce the risk of recurrence? The grade 2 meningiomas are a little bit of a controversial topic because they're in the gray zone between the truly benign grade 1s and the truly malignant grade 3s. Some people feel that if you've had a craniotomy to resect a grade 2 meningioma, um, you can just watch with scans. Other people feel that if it's a grade 2 meningioma and you know there was a residual or anything like that, that you should consider some radiation treatment up front. It's kind of highly individualized, I think, in this situation, depending upon the extent of resection, age of the patient, location, and even the pathology, because a grade 2 is they're not all the same, meaning you can have 5 different meningiomas that are considered grade 2, and they would have some slight variations amongst themselves, including growth rate. So um, in this situation, I mean, the answer that I would typically go with is to go back to the pathology report and see how they are describing this grade 2. What features or histologic factors do they see under the microscope? And based on that, it would determine kind of how I would want to potentially manage the patient. So things that we would be looking for if the tumor looked like it was a grade 2, but maybe more aggressive. Perhaps we call it a grade, 2.5 for lack of a better term. Then I'd be more tempted to consider some upfront radiation for that. So the next question was a relationship between meningioma and breast cancer in a younger patient. We talked about there appears to be, certainly a correlation between those two disorders and the hormone therapies and replacements. So that's kind of the common link there that could link the two. Not aware of a direct cause effect between meningioma and breast cancer. What percentage of meningiomas are what percentage of benign meningiomas will progress to cancerous? So that question is could be reworded as what percentage of grade 1 meningiomas will upgrade to a grade 3 meningioma, because essentially a benign meningioma is grade 1 and a cancerous or malignant meningioma is a grade 3. So what percent upgrade? That number is very small. It's low single digits, and it depends upon over what time period you're watching the patient. If you're watching a patient for just 5 years, the chance of an upgrade to a malignant meningioma is very, very remote. But if you're following large groups of patients for decades, you will see some meningiomas spontaneously upgrade over time. And what that means is, for factors that we don't quite understand, the meningioma becomes more aggressive. Maybe it is its ability to replicate increases. So you can have a situation where a grade 1 or even a grade 2 meningioma upgrades to grade 3. That is pretty rare, and it interestingly would have required at least 2 operations, because you would have to have had at least 1 operation on the tumor to establish that it was non-cancerous, like a grade 1, and then have a second operation later on and on the same tumor, and receiving a different report now saying it's a grade 3 malignant meningioma. So again, to prove this, you'd have to find a patient that's had 2 operations over a period of time, and the pathology came back differently in both operations. So it's a very unusual situation actually for that to happen. The question is that drug that I talked about, the anti-progesterone drug, the mebistostane, currently described, it was used in just that trial. I'm not aware that it's being used on a regular basis. It wasn't something that was thought to have a significant enough effect to make it clinically utilized. So, and somebody wrote, says, I was put on Lupron injections 10 years ago. Lupron injections are hormone injections 10 years ago to put me into clinical menopause. Okay. Years later, I was diagnosed with meningioma. Is it possible this hormone was slowing the tumor and perhaps it could start growing more rapidly. So we know that tumors, we know that they respond to these hormones. So putting a patient into clinical menopause, should reduce the hormone levels in your body, and therefore should be providing a protective effect. So it maybe the question is it possible that this hormone was slowing the tumor? Yes, it's possible. It's possible that it was even inhibiting the tumor, and that any growth came either before or after the Lupron hormone injection. Next question, can IUDs cause meningioma? What might this mean hormonally? And then the patient says, I went off birth control, I had 2 kids in the period of time the meningioma is formed. Currently it's a 1.5 centimeter in diameter. So IUDs, I'm not aware that they cause meningiomas. The meningiomas are common enough. We see multiple meningioma patients every day in clinic, and so having a meningioma, with being off birth control certainly could happen just by coincidence. I don't think the IUD would have anything to control that would have anything to do with the causing the meningioma. The birth control pills could stimulate it once you have it. Currently, the meningioma is 1.5 centimeters in size. It's about, 2/3 of an inch in diameter. So that's fairly small. Assuming you're not symptomatic, that could be monitored with MRI scans. If you're symptomatic, that's a different story, and you need to talk to your physician about treatment options. I had a postmenopausal, was considering hormone replacement therapy. My tumor is along the base of the skull, was treated with radiation in 2018. I've had stable results. Would it be risky to use hormone replacement therapy under this circumstance? I think if the tumor's been radiated and looks like you've had 6 years of control, meaning no growth in the last 6 years, I think it's reasonable to have to consider hormone replacement therapy, especially if you're having significant symptoms from it. The radiation takes about 2 to 3 years to kill the tumor, and at this point, if you're 6 years out, we would say the tumor's effectively been treated, and there should be only a low risk there should be only a low risk that the hormone replacement therapy would cause growth if the tumor's been radiated. The next question is, what's the role of Avastin in treating meningiomas and related brain swelling? So Avastin is it's a not a chemotherapy. It's a drug that's infused through IV. It's a vascular EGF inhibitor, or VEGF inhibitor. And what it does is it tries to shrivel up the blood vessels that are going to the meningioma. And by doing so, it can hurt the meningioma, make the meningioma shrink. It's an infusion where you have to go to a cancer center and sit there with an IV in and have the Avastin run in, and usually is repeated every 3 to 4 weeks. So it's a pretty significant investment. It's used typically in meningiomas that are refractory to other treatments. So where, patients have multiple surgeries or multiple forms of general radiation, and they're still showing tumor progression over time, then Avastin is typically used in that situation. Next question. I had a surgeon tell me that radiation makes the tumors, meningiomas, return with a vengeance. That's not necessarily true. The radiation, exposing a large area of normal tissue in the brain to radiation is what predisposes people to meningiomas. Using focused radiation, such as a gamma knife or a cyber knife, or other machine that delivers radiosurgery, it is so focused that the amount of normal tissue that's exposed to radiation is substantially reduced. And so in those situations, if you use the focused radiation on meningiomas, you have the benefit of the strong killing effect of the dose of radiation, but you're not exposing the surrounding normal tissue to high doses of radiation, which then reduces the chance of any potential side effects or somehow stimulating normal tissue to develop into a meningioma. So I would say I would disagree with that statement that was made about tumors always causing the tumors to come back with a vengeance. The next question is it unusual for increased growth of an already existing and new meningioma after a hysterectomy? Is it possible that my body kicked into overdrive, causing me to have symptoms and new growth? I have a total of 5 meningiomas. Yeah, so this is um, it is not unusual for increased growth of meningiomas in general. If you follow meningiomas out for years and years and decades, you see growth in the majority of meningiomas. And the fact that you have 5 potentially tells me that your genetics, your body is designed or it's predisposed to developing multiple meningiomas, because you're in the top probably 1% of patients with meningiomas when you have 5. So you may have some genetic predisposition for the meningiomas. I think in those situations, the frequency of monitoring has to be increased. You have to monitor with brain MRI scans more frequently. I typically have lower thresholds to treat based on the size of the tumor. If a person has one small tumor on their brain, it's not symptomatic, maybe you watch it, and if it grows, then treat it. If a patient has 5 meningiomas coming in and they're relatively, young, then I am concerned about genetic predispositions for tumors, and I usually become more, certainly more aggressive at treating up front. Um, the next question is, what other types of brain tumors are dependent on female hormone therapy? The breast cancers we've talked about. Some people feel that those they're correlated with hormone replacement therapy. So that's the other main one that I see in my practice. Um, the next question, I had a billiard ball size meningioma removed in July of 2023. It was causing a multitude of symptoms, and at the end, I thought I had dementia. So I think the symptoms sound like they were cognitive issues. Since the tumor's been removed, I've never felt better in my life, both physically and emotionally. I'm also needing less sleep. Is this typical? Um, well, it's the tumor sounds like it was large enough that it was size of a pool table ball. That's size of a lemon or orange. So at that size is likely causing significant pressure on the brain, and removing the tumor alleviated the pressure on the brain, and that allowed you to feel better. But this whole thing about maybe needing less sleep since the tumor came out, that's much harder to correlate with the removal of the tumor. So things like headaches, maybe maybe difficulty concentration, things like that, sure, those could be related, but other symptoms that we talked about, like needing less sleep, that's not really related to the removal of the tumor. Okay, another question just came in. I have a 5.6 centimeter meningioma, so it's like 2.5 inches, so it's a pretty large one. Resected in 2014. I have 2 daughters who are in their 30s, and could they be screened for meningiomas, and also caution using birth control pills or hormone treatments? So the vast majority of meningiomas are what we call solitary or spontaneous meningiomas, meaning they only occurred one time. Um, and they're not associated with any genetic disorder, any family history, or any relation to other disorders. So it's a tough call here if you're the only person in the family that has this meningioma. I think if there were more than one family member that has meningiomas, I think then it would make sense to screen um, the rest of the family. But if you are the only one with the tumor and none of your siblings have the tumor, and none of your parents have the tumor, none of your um, kids have the tumor, it's hard to justify rounding up all those people and putting them in an MRI scanner just to see if they have a meningioma. So I'm not aware that that's done in any specific practice around the country. Okay, great. We're coming up on an hour. I've gotten through, I think, 24 questions. Um, I'm happy to answer any other questions that people have. But if not, I hope this was a useful presentation and a discussion tonight. It's on, certainly on a topic that probably should be discussed more and more because of the fact that, 80% of meningiomas occur in women. And there's so many different factors that can change hormone levels that this probably should be a fair, reasonable discussion to anybody that has a meningioma that's in and around the age of 50. Thanks everybody for your time. Have a great evening and a good rest of the week. Take care. Bye-bye.